again, what I just described is the culmination of years of research of trying to understand better about what's driving this subgroup of cancers to be more aggressive. And the natural connection and what we all hope to find is to find treatments that are specific to those changes. So the whole concept of personalized medicine is being able to match a medication to the specific gene changes in a cell. So for HER2 positive breast cancer, in the past, there have been a handful of medications called monoclonal antibodies that are specific to that HER2 protein. And the current standard of care for HER2 positive metastatic breast cancer is to use a combination of three medicines. The regimen is referred to as THP because the names of the medicines are too long and complicated for anyone to say out loud. But it's two monoclonal antibodies and then a general chemotherapy where the idea is you're able to more specifically target the HER2 positive cells because of the monoclonal antibody. There's a newer class of medications called antibody drug conjugates that build on that concept of the monoclonal antibody. So that's a molecule that can find the HER2 protein on the outside of the breast cancer cell and latch onto it. But the antibody drug conjugate has what we call a chemotherapy payload or another molecule connected to it that gets then into the cell and is really effective at killing the cell. So the antibody drug conjugate is an exciting new area of research in a lot of type of cancers, but in this particular thing, this is an antibody drug conjugate that's targeted at that HER2 protein. So this study was comparing that THP regimen, the standard of care, to adding this new antibody drug conjugate plus one of those monoclonal antibodies to the regimen. And so they looked at women, they did what's called a randomization, meaning you don't get to choose which of these regimens you get. Everybody who has the same clinical characteristics gets sort of flip a coin and you're either getting the standard of care or the new regimen. And what was seen with this new antibody drug conjugate is that the progression-free survival, so the amount of time that someone was on a medication where their cancer has not started to grow again, was significantly longer with the new medication combination than the standard of care, like 41 months compared to almost 27 months. So we're not even just talking about a couple of months of extended, we're talking about years longer of time that people were able to be on this medication without having their cancer start to grow again. So that's incredibly exciting when we see this type of change or jump in the amount of time that a particular medication is effective against an otherwise aggressive and difficult to treat cancer type. The consensus in the community is maybe defining a new standard of care. So I think the clinical trial isn't fully done yet. And so it's too soon to say this is absolutely the way that everybody should be treated. But there is a general feeling in the oncology community that we may be seeing a new standard way that we should be taking care of these patients with this particular medication combination, which is very exciting. So this is a phenomenon that we're seeing a lot in cancer, which is the old way to treat cancer was much more finite, meaning you do 4 months or 6 months or even 12 months of therapy, and then the therapy ends, and it either worked or it didn't. Now what we're seeing is almost more of a shift towards a chronic illness model for a lot of cancers, where it's not necessarily something that can be cured, but it can be maintained for a very long time on specific medication combinations. So I think you point out a really key thing here, which is the amount of time that you're on treatment is very different between these two options. And one of the many unanswered questions still is how long do you need to be on this treatment and how long should you be on this treatment? Can you stop this treatment? There's a lot of different things that are still unanswered questions about what this particular regimen can do. But it definitely is a consideration both for what it means to get cancer therapy for a prolonged period of time, meaning are people still able to live well in the ways that they want to? Is being on cancer treatment stopping people from taking trips? Does it mean that they can't be parts of their community that they want to? Are they not seeing kids and grandkids and any number of things happening? So those are important balancing considerations when we're looking at regimens and what is the most important or best treatment for an individual. There are a number of those other considerations that need to come into play. Cost is also a huge consideration. The treatment is expensive, and staying on treatment for a long time is expensive. So it's important that that financial toxicity and financial awareness be a part of what is a consideration when the community at large is making a decision about truly a new standard of care treatment. Right now, I think it's too soon to tell how all of those factors will play out or what the most appropriate way to use this particular regimen will be for large groups of people. Sure. So I think the biggest limitation is that the study's not complete yet. So the data that we're looking at right now was a planned interim analysis, meaning they had, before they started the study, they had the intention to sort of look in a couple of years in and see how things were going. And that's important from a safety point of view, right? Because sometimes we find that things aren't going how we want them to, and it's important to not to continue to expose new patients to something that may be worse than what the standard of care is. So the flip side of that is this isn't the full set of data that we need to gather from this clinical trial. So the first limitation is just it's not done yet, and we need to give it more time to mature. There are always physicians who fall sort of on a bell-shaped curve of what I would call very conservative to they don't want to change standard of care until they have the complete set of information, to very early adopters, who are people who see this and immediately want to do this for every patient that they have. I think it's important as a patient to get a sense of where your doctor falls on that curve. Because as much as doctors try and keep their own personal bias out of decision making, it's impossible to not have some of those like fundamental aspects of our personalities weigh into how we take this information and think about making recommendations to patients. I think another limitation that I think may change over the next number of years as this data matures is that on this study, it was up to the treating oncologist's choice of whether or not they used hormone therapy in addition to the standard regimen for patients who were estrogen receptor positive. The reason the study was designed that way is when they started this study, there wasn't clear data that told you what you needed to do in that situation. In the last 6 months, a different trial has reported a clear benefit to adding the hormone therapy for patients who are estrogen receptor positive. And so I anticipate that more patients moving forward will probably have that part added into their regimen on this trial. And so it'll be important to see as this data, again, fully matures, what that complete picture looks like to know how to put this all together. I think the last sort of like big limitation is mostly a sequencing question. I don't think anybody will look at this data and say that this isn't incredibly promising as a new treatment option for patients, but it does still beg the question of where does it belong? Should it be the first treatment people get? Should it be the second treatment that someone gets? Are we able to define even further the subset of patients who should get it as their first treatment? And there are others for whom it's a better thing to use later down the line. Those are the additional questions that are going to need to be flushed out over the upcoming years so that we can maximize benefit of this type of therapy for patients while not overusing it if there's a different option that's going to be equally effective.